Okay, so we have a confused patient, a patient who is confused, a patient with confusion. Even the definition of confusion is confusing. So I tried to find a consistent definition of confusion that kind of drew a distinction between a confused patient, a delirious patient, a patient who has an altered or diminished state of consciousness. But when we talk about what we mean when we're referring to a confused patient, if I show up to emergency because I've broken my wrist while I'm making my coffee and I haven't had my coffee, I'm definitely not going to be able to think or reason in a focused and clear manner, as per the Mayo Clinic definition. But I don't know if you'd really call me technically confused. So I really couldn't figure out a difference between delirium and confusion. Bates and Bates, in a cool little article thing about history of presenting complaint for individual complaints, you should look it up, said that confusion is like a mild delirium. It can sometimes precede full-blown delirium. And from my own perspective, I kind of think it might be kind of sans that causative factor. Because we were taught in BB that there's usually some kind of biological cause that you can nut out and reverse. There's also that delirium kind of tends to come with those biological derangements like sleep-wake cycle interruptions and that kind of thing. But yeah, I struggled. Here's some definitions for you to look at. But in the hospital, particularly if your patient is elderly, they're post-surge, or they're otherwise sick, and then why would they be in the hospital if they weren't sick? It's usually delirium. So let's focus on that. So delirium and or confusion and or altered conscious state. I'm just going to leave the tricky, finicky definitional shit to the neuropsychologists. Okay, so what does confusion actually look like? There are a lot of things that it can look like. And I didn't really make it clear on the slide, for which I apologize, but there are kind of four main, four domains. I don't know if you can see my mouse. I hope you can. But the first four, we're looking at things like this kind of is categorized as a reduced awareness, or something is not right with how the patient is interacting with their environment and the people around them. So you've got reduced awareness. You might see cognitive impairment. Nice one, Ebb's typing. Cognitive impairment, whether that's their memory is a bit dodgy, they don't understand what you're saying to them, they're saying weird stuff to you. And then we would see things like the changes to behavior and emotional disturbances, which are really variable. You might have a patient who's got really labile affect, they might be completely flat, they might be euphoric, they might be furious, they might be agitated and hyper-focused, or they might be completely apathetic. And that's kind of what they were talking about back in BB about a hyper versus hypoactive delirium, where they said it's like 1/3 hyper, 1/3 hypo, 1/3 mixed. Look out for the hypo ones because they tend to get forgotten about because they're less of a pain. But in reality, it's just kind of a spectrum, and it's not all that clear cut, and patients can kind of do whatever they want. But if you say, okay, we've got a patient who's got some of this stuff going on, how do you know if they're actually confused or if they just haven't had their morning coffee? So there are so many ways that we can screen for confusion and conduct a formalized assessment of confusion. I've taken most of these from this up-to-date article and then a bunch from BB and other notes that I found on my hard drive. So the quick confusion screen, you can just smash it out in the ED. It's stuff like, it's the basic, like, what year is it, what month is it, what's the time, within like an hour. Remember this phrase, count backwards, say the months backwards, just like that usual stuff. I'll let you look up the details because there's the stuff about like what gets 2 points and what gets 1 point and that kind of thing. The 6-item screen is very similar. It's been tested against the MMSE on elderly patients and stands up quite well with high sensitivity and specificity. That's your year, month, day, and remember 3 items. easy way to, like, even I can remember that in an OSCE. And then sort of in comparison to that, you've got your full-blown MMSE, which we've all been taught about. That's the one you'll see in patients' ward notes, and it includes more detailed things like actually following instructions, like pick up a piece of paper and fold it and put it down, and that kind of thing, and like drawing things like the hands of the clock, or the intersecting shapes. The mocha might actually be better than the MMSE, but it's not as widely used. So it's kind of a watch this space kind of thing. The evidence would suggest that it's a more sensitive and specific test for dementia, which is what the MMSE is geared at, but you don't see it around as much, which is weird because I think the MMSE is copyright, all bound up with privacy laws. Anyway, the squid, which is my favourite one, is the single question in delirium. Does this patient seem more confused to you lately? And if their carer or their GP or whatever says yes, then you have a high index of suspicion that they're not just caffeine deprived, there's actually something going on. There are some other ones on the screen that you can look up if you really feel like it, like the confusion assessment method, I think, is a good one, which I got there twice. Nice one, Eb, you friggin' genius. Okay, so you administered your favourite delirium dementia ACS confusion screen, but now you need to figure out why your patient is confused. And for the life of me, I cannot yet figure out a way to synthesize all of the approaches to, like, there are so many reasons that people can space out on you, because pretty much anything can do it. But I thought I would present to you some structures to approach that DDX with, and by talking about the structures, we will eventually kind of get through most of the DDXs. So the first one is the MIST, which one of the fourth years taught me. So in your metabolic, you're looking at, firstly, your electrolyte abnormalities, so run a UEC CMP, and they might have hyponatremia and have brain edema, or something else cool like that. Diabetes comes under metabolic. Maybe their BGLs are really high or really low. Either of them can do it. Your organ dysfunction. The big one is your encephalopathies, which I'll talk more about later. Along with things like your thyroid or adrenal dysfunction can also space you out. And medication that either directly messes with your metabolism, like I think some people don't go well on ACE inhibitors and it bumps up their potassium, or maybe they've just had an ADR. And it's just not sitting well with them. Infective covers kind of two things. First, the stuff that is really common, like if your patient's got a UTI or pneumonia, little old lady comes in from the nursing home, she's a bit confused, you do a chest x-ray and a dipstick urine. Also covers stuff like meningitis and sepsis. And you really don't want to miss those. Your registrar will not be happy with you if you miss sepsis. No one's going to be happy with you if you miss sepsis, so do your vitals. The structural causes, first thing I think of when someone says structural is the mass. You've got a tumour, you've got an abscess. I guess raised ICP would also come in there, but we kind of talked about that. So you've got a tumour. You could have a degenerative disease, like the psychological sequelae of Huntington's or Parkinson's, or maybe they have Lewy body, or they've got frontotemporal dementia, or something else horrible and degenerative that I've forgotten to talk about. Maybe they have a stroke. It would be a really weird way for a stroke to present, and I will talk about that more in a couple of slides when I actually have info about which strokes will do that. Another one is the normal pressure hydrocephalus. So the trio of symptoms for normal pressure hydroceph is your wet, wobbly, and wacky. So wacky is like the psych, they're confused or they're a bit out of it. Wobbly, gait impairment, and wet, urinary incontinence. So that's normal pressure hydroceph. Fun little one to remember. Under seizure, nice obvious one. If someone says, oh, this person's had a seizure and now they're confused, the first thing that comes to mind for me is that there's just in that postictal state, which is really important for DDXing seizure and syncope. You can also have non-convulsive status epilepticus. So normal, like if someone says, oh, status epilepticus, I think someone's having a tonic-clonic on the floor for 15 minutes, but you can actually have non-convulsive versions where someone can just be having, I guess, a really long absence seizure. And you will see that on EEG, so put the funny hat on them. Psychological, which is not really an S, and it kind of makes me sad that it's listed there. I've got a long list of things like depression, bipolar, different kinds of schizophrenia, isolated manic disorders. Oh yeah, the fun thing about the psychological presentations, I think I'll talk about later. We'll come back to that. This is not the first time I've tried to record this, so I'm spacing out a bit. And I've got a bit of a sore throat, so maybe I also have COVID. Under your toxins, pretty much anything that can go into or out of the body, whether that's a deliberate medication that we've given someone that disagrees with them, whether they have two medications that disagree with each other, maybe they're withdrawing from a medication or something else that they've taken, maybe they have just taken something fun and they're acutely intoxicated, maybe they're poisoned. Toxins is a big one. Just a massive class. I do not have a list of every intoxication, ADR, and withdrawal that can cause confusion, and I hope I never have to, because that would be a nightmare. Okay. Reversible causes is a funny way of looking at it. It's from that BMJ article that I put up before, and it's really intended for your really severe derangements of mental status. That's like up to and including coma. So if you've got someone in front of you who is dropping their GCS, and you're like, shit, how do I DDX this? These are the things that you would do to find reversible causes. Some of them are irreversible causes too, but whatever. Okay, so on imaging, chuck them in a CT, look at their brain, and you could see a brain bleed, tumor, an abscess. Image them, look in their brain. If you think that they have been poisoned or they're intoxicated or something like that, then you run a tox screen. If they have a CNS infection, they're going to need an LP and some IV antibiotics, please, until you've cultured the LP. And also probably a septic screen and a bunch of other things. But anyway, let's keep this simple. If you think they're having a seizure, chuck on an EEG. It doesn't always, like, EEGs are not completely sensitive or specific, but they're pretty fucking helpful. And then big old metabolic panel with UEC, CMP, and blood glucose if you think they've got a metabolic or an endocrine derangement. PMN's a fun one too. So with this approach, you think about who's going to take your referral. Because y'all know that I like my emergency medicine. I'm not so interested in your little old ladies coming into their GP kind of presentation. If I'm in ED and I want to yeet this patient off to one of the med teams, or if I want to yeet this patient, who am I yeeting them to? So like I mentioned before, the psych cases, it's interesting that they often have preserved attention and preserved cognition, but the thought content is likely to be abnormal. And there are a few other things that can help you differentiate a purely psychiatric from a purely like medical or neurological. Things like, I think, an organic cause, like say a medication side effect, is more likely to make you hallucinate visually, but auditory hallucinations, you're thinking more psychological. Like that's a very classical schizophrenia kind of symptom. Anyway, neuro causes, conveniently most of them start with like M and S. I thought that was a bit cute. So you're looking at your infectious causes, which is meningitis, but also really encephalitis. So a patient can come in with meningitis and just have like the meningism from the inflammation of the leptomeninges. But if they've got a disturbance of consciousness or cognition, you'd be worried that they have a meningoencephalitis, so they've got involvement of the brain parenchyma as well. They might have a mass, a space-occupying lesion. Often that will be in the frontal lobe, because that's where all your executive function and personality and all that cool shit happens. It could be like an abscess or a tumor or whatever else have you. Your SA, SD, and IC. So subarachnoid, subdural, and intracranial hemorrhages. If they've got a bleed, that can make you a bit spacey. Stroke, like I said, it's a rare presentation, but here's the note about which strokes will actually mess with your cognition. They tend to be ischemic. They might affect the basilar artery, or you might have a bilateral infarct of the thalamus. And don't ask me what you would have to do to get one of those, but either way, they're not common presentations. If someone comes in with a stroke, you're much more likely to see something like a dense hemiplegia, or even that really weird vertigo presentation that we had from Dr. Koh the other day, than someone who comes in with an isolated confusion, or confusion is their primary symptom. Like, stroke is not the first thing on my DDX list. Seizure, I talked about, that's your postictal or non-convulsive status. Dementia, I hate it. It gets its own lecture. Med, oh god, it gets its own slide. So, like I said before, pretty much everything can give you, can mess with your state of consciousness if you're ill enough or vulnerable enough. I didn't really format these all that well when I first did them, but here are some pretty circles. And this is the way that I find helpful to think about it. So first three here in, like, with the red thing, don't miss these. They will kill your patient. So check the sats, check the glucose, check the vitals. Encephalopathies, like, I'm trying to figure out a good way to explain this, but it's like if you have a focal disease, like you've got hepatic encephalopathy, that is like you've got a disease of the liver, and because of the physiology of how that works, you've got a build-up of crap that then affects your brain. As opposed to other infections like UTI or pneumonia, or I guess like a septic arthritis or whatever else might be going on, where I don't, like, unless I've just failed to research it, it's not really that clear why a little old lady with a UTI will come in absolutely off her rocker. Like, it's not the uremia, if she hasn't got the AKI kind of thing. Anyway, infection, really common. Then there's all your funky tox stuff. So they've got the DTs, or they've got a side effect, or they've got two drugs they shouldn't have together. And then there's the fucking everything else. Because anything, whether or not it messes with your biochem, anything in the right patient can cause confusion, delirium, altered consciousness, what have you. And I added this little star down here to myself to not forget about the pure electrolyte abnormalities. Because I know I'm going to be the kind of person that just forgets to run the CMP. But confusion is not an uncommon way for an electrolyte abnormality to present, although you'll probably also see like stuff on ECG and whatever else. So, if you are the kind of person that just likes to reel off investigations to your reg, and then justify them afterwards, this is the approach for you. So, everyone gets a finger prick, O2 sats, and chuck on the full set of vitals just while you're at it, because you don't want to miss hypoglycemia, hypoxia, sepsis, coronavirus. If they have a decreased conscious state, I'm forgetting how to English, I'm really sorry, do your metabolic panel, UEC, CMP, everyone gets an FBE, but that's just what UpToDate put it under, because this is where UpToDate is where I got this approach from. If you think they have an infection, chuck on the ECG, do a urine dipstick. So the ECG for like demand-related ischemia, dipstick and chest X-ray for those focal sources of infection, and also part of your septic screen. So chuck on blood culture and maybe an LP if you're that way inclined. If you're worried about an intracranial pathology, and before you do that motherfucking lumbar puncture, because I know I'm going to kill someone by doing an LP when I haven't done my CT, do the CT. And if you're worried about tox, do a tox screen. Obviously, this isn't a complete list. This is the UpToDate kind of abridged UpToDate version, but Geeky Medics has a really nice long version. And there probably is a formal confusion screen, like a septic screen, that I should have looked up before I recorded this, but oh well. So these are the ones, like if you're into your common versus killer causes of things, these are the really common garden variety causes of confusion, other than my caffeine withdrawal if I don't get my double espresso in the morning. Depending on where you are in the hospital, like 50+% of your patients could be delirious. I think it's like maybe 30-40% in med, 50% in surge, even freaking higher in ICU. Whether that's because they're disoriented to their environment, they're just coming out from anesthesia, they're having a drug reaction that's just a drug side effect, or if they're sick, which is why they're in hospital. Like I mentioned, pneumonia, UTI, really big ones in the elderly, under ear infection. Don't forget the meningitis. Drugs, also things that can affect you in hospital, whether that's prescribed medication side effects, interactions, withdrawing like in your DTs, they're acutely intoxicated, they are drunk as fuck. Again, emergency medicine will get that. And then again, metabolic imbalance, just all of those biochemistry things, but drill down to the cause. Because if they are drinking so much that they've diluted themselves and given them cerebral edema, there's probably something else going on there that you want to investigate. And then these are the ones that you really don't want to miss. Sepsis, meningitis, hypoxia, hypoglycemia are the ones that are more likely to present with altered states of consciousness. And because literally anything can cause an altered state of consciousness, you also always want to have in the back of your head the other shit that will kill you. So an MI, stroke, PE, I don't know, massive hemorrhage from somewhere. I don't know, pretty much anything can do it. But yeah, I hope that someone found that helpful, because dear God, I could not have confused myself more. I could not have been more confused by trying to make notes about confusion.